Brought to you by the Parekh Family Foundation. This past year has been a challenging year for all of us around the globe, with COVID affecting every inch of our lives, whether it's your work, your friends, your family, travel, even going out to eat. We have all had a lot of stresses. Our foundation, since 2008, has been training and educating surgeons from around the globe and has held surgical camps for foot and ankle, initially in India and then many countries throughout the world. However, 2020 was a challenge even for our foundation, and none of our usual activities could be performed. So our team decided that for 2021, we would come up with this one-of-a-kind 24-hour case-based session with 24 topics hitting 24 hours, all time zones continuously. We've got a fantastic 24-hour lineup. We've got over 100 faculty members. These are key opinion leaders in their field in foot and ankle and very well respected in what they do. So you guys are in for a 24-hour treat, but don't worry, if you miss it, we will be recording these and it will be available later on. Now, the one last thing I want you to remember is there is a chat box, so feel free to ask questions as the hours go on, as cases get discussed, because we will try to get to these questions throughout the sessions. And without further ado, I'm going to kick this off. Mark Easley is our first moderator. He's a dear friend. He's the chief of foot and ankle here at Duke University. And he will be talking about ankle arthritis and ankle replacement surgery. Our sponsor for this session is Smith & Nephew. So thanks, Mark, take it away.
Thanks. Can you see my screen?
Yes.
Oh, perfect. Okay, good. Thanks, Selene, and thanks for all that your family does. My faculty, Dr. Davis, Dr. Demetracopoulos, Dr. SanGiovanni, Dr. Amendola, and Dr. Daniels really appreciate the opportunity to participate in this and hope it's a great success. A lot of pressure on us to get things started off right. So ankle arthritis and total ankle replacement is our topic. So we will try to cover this as best as possible. So I'm going to start off with what are the indications for arthroscopic debridement, distraction arthroplasty, and periarticular osteotomies. And this is not the focus of this session, but we definitely need to cover these bases. So I'll turn it over to Hodges. And Hodges, if you just tell me when to advance the slide, I'll take you through it.
Yeah, so you can advance it. Basically, I'm going to start with a case, 39-year-old. We all see these. Had an ankle fracture as a college student, ankle pain, has got kind of global metatarsal pain because of this chronic equinus, no foot deformities. Obviously, this is somebody that we would love to save his native joint so that we don't have to do a fusion or a replacement. Go forward, Mark. His CAT scan doesn't help us at all. The front of the ankle is kind of trashed, but he's also got some subtalar arthritis, which a lot of these do, as well as talonavicular arthritis, which changes our approach. Next. And next. So in trying to just save him, I did an open anterior chylectomy with an anterior incision. I used a smaller than my ultimate total ankle incision. I did a gastroc slide. I put some bone marrow in there, kind of shooting for the stars. Next. I mean, he's glad he's plantigrade, but what can I really tell him about how good this is going to do after this operation? If he had instability, I would have fixed it, but he didn't. Would he do better if I would have used the scope for these big deformities? And what about open incisions? Is there any literature that says that an open incision with a good clean out is better than that? And then finally, do we make him worse with intermittent injections, PRP, viscosupplementation, and heterotopic ossification? So what we know is that we know we can do a lot through the scope. And I've always said that that if you can scope it, you can hope it. Next. And the literature really supports that. Here's from Dr. Mafuli, which has a lot of, he's done a lot of things with arthroscopy, specifically looking at professional soccer players. Next. And what he found is that anterior arthroscopy really can do better, but only with mild disease. And he doesn't really tell you what mild disease is, but we kind of get a feel what that is. So For mild disease, mild anterior impingement, arthroscopy does help. Next. And this out of the Journal of Sports Medicine said the same thing. Next, that arthroscopic in 46 patients, as long as they weren't end stage, it certainly did help, and it did better than open. Next.
Yes, sir.
Yeah. So the bottom line is, as in this study from Ned's group, I think before he came to Duke, certainly he showed that the scope can't make a bad ankle great. Next. And the underlying diagnosis of significant osteoarthritis showed poor results despite a long history of good arthroscopy. Next. So bad ankles do bad with scope. Bad ankles do poorly with open debridement. And so the bottom line is, in this study in 95, that doing the debridements in people that have really significant arthritic changes really does not make a difference. Next. Thanks.
Good, perfect. Yes, so I'll turn it over to Tom, and we want to focus too much on this, but Tom has some thoughts on this too.
Right. Thank you, Mark, and thank you, Selene, for inviting me and everybody to talk.
Yeah, we lost you, Tom. See if you can put your mic back on.
How's that? Good?
Perfect, yep.
Oh, good. Oh, great. So Hodges touched upon this, and I'm going to try to go fairly briefly so that we can get to the other topics, which are probably of much more concern. So this is a quick case, 65-year-old, recently had an ORIF of his ankle, had medial-sided pain over the hardware.
Yeah, we lost you again. Try one more time with your mic.
All right, let's see.
There you are, you're back.
Okay, great. And so he wants the hardware out, and can something else be done? Next. Anything that he can do for this anterior pain, as well as the pain that he has that's more like an arthritic startup type pain. Next. So I go through the whole system, we go through a whole spectrum of operations that can be done. And then at the very end of a very long discussion, he's like, okay, that's nice, but can't you do one of these cleanups, like one of these laser scope jobs? So he wants a quick recovery, and he doesn't have time for a big surgery. Next. So open versus arthroscopic, who's the ideal patient, some technical tips, and is this procedure even appropriate or effective? Next. So our typical arthroscopy setup, I'm not sure, you can see an anterior osteophyte, but what's most important is how much arthritic changes there are. Next. I don't know if Mark, if you can hit maybe where the osteophyte is. I'm not sure if the video will work. Keep going.
Yeah. I may not be able to. I'm sorry. I'll close you. Sorry about that.
No worries. But anyway, it's a matter of really some tricks are having the appropriate size burrs, having some good sharp chisels that you'd be able to get in through it might have to open up the portal a little bit more. Next. One of the things I found helpful is that sometimes you need a bigger scope, so like the knee scope. So the 2.7 is sometimes not very aggressive. What works really nicely is an acromonizer. So it's something for shoulder surgery because it's more oval and it's broader. You get faster working time, but it can be a little bit more aggressive. But next, but don't worry, everything's going to be all right. The next case. Similar but less arthritic changes, and it's more anterior pain that he's having, sharp anterior pain, episodic. Next. And this, you can hit this one again too. Next one. And once again, it's just basically being able to burr down the osteophyte, try to open up some space. Next. And keep going, Mark. You can go to the next one. Getting adequate decompression through the scope. Now, most of these osteophytes are intra-articular, so you should be able to get to them with the scope. One of the problems, though, is some of these patients are really fibrosed, so getting adequate visualization is an issue, too. So a little trick I have sometimes when you get that ankle is sometimes you have to take them out of the traction and even dorsiflex and open up a little clear space. Dr. Van Dyke talks about that a lot, and I think that is helpful in these very stiff ankles. Using a blunt trocar and just kind of dragging it across, finding your joint line and just dragging it across bluntly, or using your shaver to try to drag it across so that you're not creating any iatrogenic injury, but you're able to see. Okay, next. And this is what you want to see. I mean, you want to see a better joint, clearer joint than the previous one. Next. This is what you don't want to see. Okay, so when you see this, the long-standing relief, it's not going to happen. Probably if they have anything short-term relief, you may get a little bit if they have loose bodies, but you're not going to win. And this is a similar case, let's say, pretty bad trauma, but what Hodges was saying before too. Sometimes you do have to open these if you're worried about, let's say, causing injury. If the osteophyte is just encapsulated, it's so intimate with the capsule that you're worried about causing an issue. Sometimes you have to open your portal to it. But the results really show that you may get some relief with the arthroscopic, but it's really going to be dependent upon how arthritic, how many chondral changes, how bad the joint looks in the long run. And just some final points. Most of these you can get arthroscopic because osteophytes are intra-articular. Some you may need to do a mini arthrotomy. It won't look like you took off much. Next. And it's really dependent upon the arthritic changes that you see. And that's really
got it.
Yep.
That's good. That's perfect. All right, good. Got it. So Ned, how about distraction arthroplasty? You did some research on this. What can you tell us about that? Is it worth doing?
Yeah, I think that's a good question, Mark. And I've been doing less and less of these since I looked at the series that we did in Iowa. If you can go to the next slide. This is a very brief presentation. So everybody's familiar with distraction. There's a lot of work that was done on it. We did a lot of laboratory work at Iowa. Next slide. And it really came from this. This is one of the original studies from the Netherlands, from Van Roerman, that really showed that there was some benefit. But even in this study, 1/3 of patients had failed by 6 or 7 years following distraction. Next slide. And so there is some usefulness. This was one of my patients, a 33-year-old lawyer from Kansas City. You can see before distraction, and then next slide. You can see after distraction at 18 months, and next slide. Here at 4 years, and he was still happy with his ankle, but see, he's kind of recurred the anterior osteophytes, but he's got a symmetric joint space, and he's continued on. So some cases do well. So this was the study that we published in JBJS. And next slide, this was a randomized trial. We compared motion to no motion. Both groups improved by 2 years following surgery. So there was some hope that this was successful. Next slide. We continued to follow these patients, a minimum of 5-year follow-up here, an average of 8.3 years. And now you can see that 50% of the patients at the end of this follow-up had gone on to arthroplasty or arthrodesis. Next slide. And there was significant degenerative change over time with cystic formation, joint cartilage loss in these patients. Next slide. And there really hasn't been much else in the literature. This is from New York, from Robert Rosbrook. Again, the same results. You can see the survival goes down over time, at over the 5-year period. And so there are some specific indications. This is another study from New York, from Kennedy, showing that doing some biologic stimulation with distraction really did not change the results, no additional benefit. And so I think it has very specific indications, very work intensive. There's complications in 100% of the patients with pin tract infection. So I think you need to be careful. So I think with the discussion of other options, I think distraction arthroplasty, at least in my opinion, has really kind of gone down in terms of a good option.
So what about, can we get Constantine involved here? Can you tell us about this case?
Sure, Mark. So this is a case of a 43-year-old male presented to me with instability and a medial osteochondral lesion of his talus, and he'd failed previous non-surgical management and had a previous arthroscopy for his osteochondral lesion. And so if you go to the next slide, you'll see his x-rays. And this is the paradox for me for supramalleolar osteotomy, because often the patients that are going to do the best are the ones that when you explain to them what a supramalleolar osteotomy is, they look at you like you're crazy and they don't want any part of it. So here's a guy who's already had an ankle arthroscopy, has a chondral lesion on the medial talar dome, has some talar tilt, and has a varus hindfoot. And I didn't think it would make sense for me to go do another arthroscopy and try to clean it out. And so he's one of my better supramalleolar osteotomies that I've had success with. So if you go to the next slide, you see here that I did a medial opening wedge osteotomy and a closing wedge osteotomy of the fibula. And I think that adding the fibula doesn't really take much time, and it helps, and it rarely hurts. And so I encourage others to try it. You can see I did a lateral ligament repair also. I didn't do an arthroscopy. I left the ankle alone, and you can see his tilt is much better. And if you go to the next slide, you'll see here, and click it once more, you'll see that I took his varus hindfoot and I did a lateralizing calcaneal osteotomy, a Malurba type osteotomy. And if you click it once more, you'll see that the heel is much better centered under the tibia. And so this may seem like a lot of surgery for a poor guy with an osteochondral lesion, but this was a young man, very active, liked to do running and CrossFit, and despite all the surgery, he was able to get back to playing sports, running and jumping. And so I think this was a good case. So my take-home points are to aim for overcorrection, but not too much. I've seen cases where if the primary goal is to correct the talar tilt, well, then the overcorrection may be too great, particularly in cases where when an external fixator is used to dial the correction until the talar tilt corrects. Sometimes the deformity that's induced is too great. So aim for overcorrection, but not too much. Yes, it's great to correct the talar tilt, but it's not so important. Pay attention to the core, because if you do your osteotomy at a different level, you'll translate and have a low threshold to cut the fibula as well.
Thanks. Yeah, good. So Ned, you've had a lot of experience with this too. We'll circle back to you about supramalleolar osteotomies.
Well, this is a similar case presentation for 44-year-old, very active, long history of ankle instability, and has all the findings you'd expect, with varus alignment and a positive anterior drawer. Next. And you can see here the varus and the chronic adaptation to the varus instability with that lateral subfibular osteophyte, the anterior subluxation of the talus, anterior osteophytes. So in addition to what Dimitri just presented, I think you need to take care of the other associated findings. Next. So, we looked at the whole limb alignment, and the thing here is they do have varus of the tibia. Next slide. You can see here, it does have about 10 degrees of varus of the distal tibia. So I think this is ideal for supramalleolar osteotomy. Here's the CT, nothing surprising here. Next. And the MRI shows the same thing with in terms of anterior subluxation, anterior spurring, the lateral findings. And so next. We did a similar, I don't know what happened here, but
I don't know. I can't make it go through its. Did you have several images on one?
Next,
Shoot.
Next.
Yeah, I don't know if I can change that. There we go.
Okay. So we did the same thing, an opening wedge. I do the fibular osteotomy obliquely first in every case. Then I do the opening wedge, fix the tibia, and then I fix the fibula wherever it lies. Next, I took off the osteophytes, did a lateral ligament reconstruction. And he just came back a couple months ago. He's 3 years out, doing very well, very happy. It's not perfect, that you can see there, but he's doing very well, and it's very worthwhile surgery.
Great. So it sounds like there is an indication for it. We're going to talk about ankle replacement. And so I'm going to turn this over to Tim, who's done a nice job of leading us to the next few topics. So we talked about debridement, distraction, supramalleolar osteotomies, but Tim, you want to take us through putting this in combination with some of the other procedures that we do?
Thanks, Mark. I look at osteotomies surrounding ankle arthritis as a black box. I mean, every time an article comes out with, you know, a title of supramalleolar osteotomy, I always go to it, migrate to it first and read it. But I'm always disappointed because it doesn't seem we can ever come to a true consensus as to when to do these osteotomies, or how to do them, or how frequently, or do you combine them with the total ankle replacement? Do you stage them? It really is something I think is still evolving. So I want to present to you three difficult cases that I had and what I've learned. So this gentleman presented with a previous lower tibial fracture. He's obviously got a varus deformity. You can click your mouse there, and you can see he's got about a 15-degree deformity with some recurvatum next of about 9 degrees. So this is a biplanar, probably triplanar deformity. And so you can click again, Mark. Here's his hindfoot alignment view next. And what you can see in the hindfoot alignment view, and I look at these quite frequently next, is that his calcaneus is fairly well aligned. So he's got increased varus of that tibia plafond, but if you look at the midline of the tibia and the calcaneus, you can see that there's been some compensation through the subtalar joint. Next. On the lateral, he's got recurvatum next. But you can also see he's got a bit of a cavus foot on the pathologic side. There's an increased distance between the base of the navicular and fifth metatarsal. I ignored this, and next. Because his calcaneus is fairly well aligned, I went ahead and did this tibial osteotomy. I dual plate them now, but he seemed to do very well at the beginning. I was quite proud of the x-rays. I think I showed this at a few meetings. Next. Next. We didn't really correct his recurvatum, but there's nothing like follow-up. This is 2 years later, all right? And I'm looking at his x-rays, I'm thinking something doesn't look right here, and it didn't. I mean, he basically went back into varus, and I was convinced he was healed. So, you know, what is going on here? My conclusion was that I wasn't aggressive enough at correcting the foot deformity. And maybe even doing a 3-foot standing view, seeing if he's got some varus up at the knee. I'm not sure, but there was constant deforming forces occurring through this tibia that caused it to actually collapse and the hardware to give way over a year after the surgery. So I'm much more aggressive at correcting the foot deformity now. Next. Here's another case. This is again a fairly significant deformity, a distal tibial fracture. Next. In my practice, looking at this deformity, it's correct. It's something that I can't ignore. I need to correct it. Next. And you can see on the hindfoot alignment view that next. Again, there's some recurvatum. It seems to be very common on the lateral, but there's also varus of the hindfoot. Next. So in this case, I was much more aggressive with the osteotomy. I dual plated it. I didn't plate the fibula in this case. You can see there's a knee replacement above. And then I did stage this one. I did the ankle replacement and did a foot reconstruction afterwards. So I wasn't going to fall into the same trap that I did with the previous patient. Next.
Okay.
And this is my last case, Mark. This again is a situation where this lady had some varus, but it was less than 10 degrees. So I thought I could ignore the varus deformity at the tibial level. Next. Next. And if you look at her hindfoot alignment view, you can see that there is some varus. Next.
Man, you got a lot. I'm trying to keep up.
You're good. You're good. You're doing great. And you can see that the subtalar joint on the lateral x-ray had some arthritis. This was a rigid hindfoot. Next. So once again, I ignored the fact that her hindfoot was in varus. I thought the tibial deformity wasn't severe enough. Next. Did the ankle joint replacement, and she didn't like it. She came back with medial base pain. Now, a lot of people looking at this might have said, to me. You should have known this ahead of time, Tim. But again, I'm paying much more attention to the mobilization of the hind foot and the position of the foot. So you can see that calcaneus was still in varus. She was overloading the medial side. So a year after her ankle joint replacement. Next. There's the, you can see there's, the reason you're looking at the tibial implant in that view is because there's still recurvatum at the tibial fracture site. Once again, a very common deformity to see. Next. So I at about a year and a half afterwards, I brought her back, did a tibial osteotomy. You can see that I realigned her in both planes and she was pain-free. So my take-home message here is, number one, don't just look at the tibial deformity, look at what's happening to the foot below. If there is an associated varus deformity, the hind foot, or a cable varus deformity, that needs to be corrected at some point, either at the same time as your ankle joint replacement or stage it by 2-3 months, whatever is best in your practice. But look at what's happening to the hind foot. Get that calcaneus aligned. And Constantine gave an excellent example of what he did for that patient. It's imperative to get the rest of the foot aligned, regardless of what's happening at the tibial level, because if you don't, eventually the medial sided forces are going to stress your osteotomy to the site where either you're going to have persistent pain or recurrence deformity. Thanks, Mark.
Perfect. All right. So let's take this then. It was a good introduction to get to ankle replacement versus arthrodesis. And so Hodges, let me circle back to you. Why don't you take us through your indications and algorithm for this?
So with me, I always say what makes me push a patient towards a total ankle versus an arthrodesis, because I still do arthrodesis. And the key is pre-existing hind foot problems, whether it's a hind foot fusion, which patients with degenerative ankle and hind foot fusions is what got me interested in ankle arthroplasty in the first place. Significant degenerative hind foot. The issue that fusions are just a bigger deal, and they're harder to come back, also will push me in an older patient towards that. Next. So what about pre-existing hind foot fusion? So this is an article a while back from the Andy Cracchiola's group, but it basically has mirrored what my examples is, that a pantalar fusion, patients do horrible from it. And next, they only had 5 patients in a fairly large series that did well. Next. So how good an operation is an ankle fusion? And I would propose that an ankle fusion is a great operation if they have a great hind foot. So this is 9.3 years, 73% were good to excellent. They were worse if you had a malunion of the ankle fusion, which I think we're better at that now than we were when I started, or if they had subtalar disease. So I think it's a good, not great operation. And if you leave them with residual deformity, or they have ipsilateral subtalar or talonavicular disease, the results are not good. And it's interesting to see, the longer I watch my ankle fusion patients, the more I find this to be true. Next. So you need a normal subtalar joint to have a good result. It's interesting though, I talk to docs and they say, I live in a small town, I can't survive disasters. And so that's the reason why I can't do total ankles. Well, I believe that our disaster stage of total ankle replacement is past. And in fact, I see more disasters after fusion. This was out of our center. We looked at in-hospital complications as well as readmissions with ankle arthrodesis, and it was much higher in our arthrodesis patients than our ankle patients. Next. So in my older patients, ankle fusions have this long, inconvenient postoperative course. So in the total ankle, they're walking on it in 2 to 4 weeks. In an ankle fusion, they're on crutches or a walker for 6 to 8 weeks. Extended casting with ankle fusion, and they really don't even get into physical therapy for 4 months. Where in my ankle replacement, they're out of a boot in 7 or 8 weeks, and they're getting motion and getting back to life. Next.
Yeah, so thanks, Hodges. So Constantine, you want to share with us your your algorithm or your thoughts?
Sure. So a lot of this is what Hodges just said, and I tell patients that an ankle replacement is a shorter recovery. I think it's easier for older patients to have a replacement than a fusion because they can start putting weight on it much earlier. People with a replacement can do better with uneven ground, so they can do better in terms of hiking, walking on the beach. The pain relief is reliable with an ankle replacement, but I do emphasize with them that a replacement is a procedure to take away your pain and preserve your motion. So if you go to the next slide, Mark, who gets an ankle arthrodesis from me? And it's rare, I must say. So I'm definitely biased towards replacement, but patients with neuropathy, progressive neuropathy, lack of protective sensation, poorly controlled diabetics, patients with avascular necrosis, poor bone quality, history of osteomyelitis, and really a lot of this is relative. If someone has a little bit of avascular necrosis, well, maybe you can excise that bone and still do a replacement. Or if they have a history of an infection but no recurrence 30 years later, and you do the appropriate workup, well, maybe they can still get a replacement. And then some relative things like too young, too active, or too heavy. And those things have changed as I've progressed in my career. So if you go to the next slide, what we know is that patients with an ankle replacement or who get a replacement have higher pre-op expectations than patients with an ankle fusion. But both groups are equally likely to meet their expectations. But a greater proportion of replacement patients have satisfaction or have an increase in their satisfaction after surgery. So if you go to the next one, Mark, many of our studies have shown equivalent results of replacement infusions. Many of those are older studies, but more recent studies, and this was a great prospective observational study that was done, that really showed that over the long term, people with a replacement have better functional scores than people with a fusion. And if you click to the next one, why would that be? Well, replacement patients still have motion, so they're engaging their calf muscle. They still have push off, and so they walk faster, they take bigger steps, they take more steps, and so they're able to do more things. And so I do think that when it can be done safely, it's a better option than a fusion.
Yeah, good. So I'm going to turn this over. I think we'll have to do one share screen in a minute, but just want to know, what are your keys to success if you fuse an ankle, if you do an arthrodesis? Here's just a patient of mine, just look at the talar dome, just looked terrible. I didn't think that it could support an ankle replacement. Certainly we have implants that may be able to do this, but I decided to do an ankle arthrodesis. So I want to hear what preferred techniques are. This is what I do, I usually use an anterior plate, and then I just want to make sure I put it in the proper position. So this is just a case of mine. I usually confirm it. I get the CT scan, not to waste resources, but just to confirm, because on two-dimensional x-rays, I can't tell if it's definitely healed. So Tom, I'm going to circle back to you. Maybe you can teach us. Sorry, your slides are really, really cool. But somehow when I brought them over to me, there's a few overlaps of pictures. So maybe you can just talk us through this real quick of your thoughts here.
Sure, no worries. Yeah, I agree with all of you guys. I'm certainly excited about ankle replacements as they came along, and have gotten more excited as time has passed. Over the past 20 years, I looked at my my data, and over the past 20 years, it was about 70-30, 70% total ankle, 30% ankle fusion. But over the last 8 years, there's been, certainly more of a trend to total ankle replacement. And I think some of it's been the technology. The precision is much greater, especially with the PSI. And also our salvage options, I think, are much greater now too, with the 3D printing that's going on. That we always have to worry, but not as much. So I kind of look at some of the contraindications to arthroplasty, and some of these now I think are relative, but that gives me an idea of like what people are kind of in that arthrodesis category now. So I'm looking at the opposite direction, and obviously severe deformity, like excessively severe deformity, and these things that you can still do, that you can correct rather severe deformity with arthrodesis, long-term durability, it's all there, but it does place increased stress on the adjacent joints. And if they are starting out with a stiff hindfoot, you want to keep a mobile segment somewhere, so let's just quick case, 78-year-old gentleman, multiple comorbidities, poor skin appearance. Next, this would be one that I would do arthroscopically. I mean, certainly you could do open, but I've been doing these a long time, and I feel like the biology of this, trying to preserve, I can get a very good joint prep arthroscopically, or if I have to do a little mini open or mini arthrotomy, I could do that as well. I supplement with usually autogenous graft. Used to take from iliac crest, but now I can take it percutaneous through the proximal tibia and get very good bone graft to place in. And then I'll put I'll put my screws in from different directions, and I'll show you in the next slide. I corrected the forefoot and hind foot as well with this. This was just 2 screw fixation, and that may be adequate, but you still have to do a very good joint prep. Your screws, you want to put them somewhat vertical. You don't want them to cross at the level of the fusion. So you want to cross, if they're going to cross distally. It's like a supracondylar fracture in a kid. You don't want the wires to cross at the fracture site, because it's going to lead to less torsional control. Next. If you need to do a mini arthrotomy, it's easy to do. You just open up the portal a little bit more and have I have like these nice little instruments, these little tricks to help with the denuding of the cartilage. And then once I get that, I either subcondylar drill, or I'll like to feather the joint with a flexible chisel and then put the graft in. And there are various things that you can do for grafts that I've done throughout the years. You could use a minimally invasive cancellous graft. You can aspirate from the iliac crest. If you're doing it open, I would do a fibular sparing, where I just shave a little wafer of the distal fibula, and then I use like a Gaitner gouge, and I'm able to get graft from there. Next, 2 screws, 3 screws. The big thing is you want adequate joint preparation. Nothing should be less important than that. Okay, and then getting compression. Right, open procedures. I've had a few non-unions, so sometimes I feel like the plating in combination with compression screws, placing the compression screws first and the plating afterwards, has helped in some of these cases. So, and there are various plates from posterior I don't have much experience with, but I'm sure it's a good construct. Once again, you got to address the biology and the mechanical aspect. And then X-fix is, X-fix is when you have those certain scenarios, whether it's infection or leg length discrepancy, various things that you have to have that in your armamentarium. It's painful, but it works. And just optimizing is just really pay attention to the biology, the anatomy, alignment, and mechanics. You just can't think one thing. And it's really better.
Perfect. Yeah, no, that's good. Thanks. We have just 20 minutes left, so we want to focus on ankle replacement. So,
Mark, we have a question, if you don't mind, and it might be now.
Yeah, sure.
So, 51-year-old with a pilon fracture. When do you, who has ankle arthritis and a lot of pain, when do you guys pull the trigger for ankle fusion versus ankle replacement? And are any of you using age any longer as a criteria for offering ankle replacement?
Yeah, Ned, we haven't heard from you in a little bit. What do you think?
I think age has become less of a indication or contraindication. I think age 50 is probably reasonable in my mind to consider a total ankle replacement. So I think a pilon fracture with ankle arthritis, I mean, obviously you have to evaluate it, evaluate the soft tissues, evaluate any history of infection and like that. I mean, in this particular picture that you have here, I think, if that was a pilon fracture, I'd be hesitant to do an ankle replacement. But, for Celine's question, I think ankle replacement has become a much more common surgery in my hands over the last 20 years.
Yeah. Tim, what do you think?
Well, this is an exciting time. I mean, we can't look at these two procedures as one being better or worse than the other. They all both have their advantages and disadvantages. And I think it's so exciting to be able to offer our patients either one. I'm definitely doing more replacements now than I used to do. because we've actually are publishing several studies to show the advantages of ankle replacement over fusion, and has more to do than just cadence and speed of walking. It's has a lot to do with just proprioceptive feedback and patients feeling like they have a normal hindfoot. But having said that, I still do a number of fusions. It's, you know, soft tissue integument's poor, maybe they've got neuropathy. There's multiple reasons to do a fusion. There's multiple reasons where they'll do better with an ankle arthroplasty. So I look at both procedures as good procedures with indications that that should be adhered to.
So Tim, you've come a long way. I remember a time when I was doing ankle replacements in Canada and you were not doing any.
Yes, I did my first ankle replacement in 1999 and gradually increased my numbers.
Yeah, I started in 1994. So I'm glad that you're moving forward.
I probably gave you a bit of crap too, Ned.
A lot. You gave me a lot of grief.
All right, well, that's really great stuff from our Canadian colleagues. So that's about enough of that. Hey, real quick. So Ned, spearhead for us just real quick. We got to move through this a little bit here so we can get to some of the total ankle, but these are some of my patients. How do I avoid these wound complications? Just some tricks. And then if anybody else wants to throw in their tricks, just 2 minutes. Just how do you manage the soft tissues? How can you avoid this?
I think the first 6 weeks after surgery are very critical in allowing the soft tissues to heal. So I think the ankle replacements are solid. You put them in, but I think they should be treated differently than knees and hips. I think you should immobilize them and ensure that the soft tissues are well healed. So I think, you know, evaluating the patients beforehand, making sure they can heal the incision, but protecting them from doing any activity and immobilizing. So I immobilize all my total ankles for the first 6 weeks.
See, and
Johnson,
Mark,
yeah,
I
go
would
ahead,
say,
Hodges.
I think that's how you get stiff toe ankles. So I mean, my deal is get in, get out, respect the soft tissues. I'm fine to leave the stitches in for 4 weeks, but I'm moving them at 2. I have no problem not walking them till 6 weeks if the wounds are a problem. But I believe that a stiff toe ankle, I think we have to be a little more aggressive in moving. I am fine not to walk them because ultimately I think that often puts more stress on the wound than just movement.
Perfect. All right, let's move along. So irrespective of the implant used, okay, so we got all these different ones on the market. And a lot of these show some common trends. But what are the keys to success in performing a total ankle? So let's just spend a few minutes. Maybe Tom prepared some stuff, I know, but we're going to run out of time, I think, to switch to another screen. But just some tricks. Let's just run down the group here and just say, just it doesn't matter what implant you use. What are some of your tricks to make sure your total ankle is going to be the best it can possibly be? Tom, why don't you start us off? Just give us a couple of your pointers of what you think are the keys. No matter, you've used several different ankles. What do you think? What do you need to do to make this work?
Certainly, I think alignment's very important. And I think probably the most difficult thing with alignment is judging the rotation, I believe, of the implant. And that's probably the toughest thing, I think. I think with the PSI, that's certainly going to be a lot better, especially when PSI becomes weight-bearing, like with weight-bearing CTs. But I think that's the hardest thing. So nailing down the rotation. Other things that burn you early would be what you showed, the wound. So paying attention to your assistants, make sure they're not just sitting there retracting like crazily on the incision. And then I've gone to probably the last year using a wound vac, either wound vac overnight, and they stay overnight and take it off, and then or a Prevena. And either those negative pressure or suction devices, they've made the wounds look tremendously better in my hands. So,
Tim, what do you think? What do you do to make these work best, your total ankles?
Mark, I got to put a plug in for the extensile antral medial approach. We've published on this, and we got a video in the AAOS library on it. It's a large medial lateral base flap. I've had minimal wound healing complications once I've adopted this approach. As far as getting a pain-free ankle, I am a staunch believer in doing just as much work around the ankle as you do in the ankle. And I do not feel that the ankle joint replacement should be the most complex part of the procedure. It should be part of the hindfoot reconstruction. We do ancillary procedures in over 65% of our cases, and that includes ligament reconstruction, clearing osteophytes from the gutters, maybe debriding the subtalar joint, cable varus or pes planus reconstruction, multitude of procedures around the ankle to make it as good as you can get it.
Yeah, it's amazing. They're just, there's lots of great things that have evolved, and I like that there's competition in this because I think it makes us all better. So those are all good points. There are a lot of melding of ideas and a lot of things we still need to learn, but it's really been fun pushing it forward. So how about deformity correction in total ankle? Here are just a couple of my cases where I've, medial releases and, like you said, a lateral ligament. And then I've even done osteotomies like Tim showed around the ankle to try to make it better. You've got quite an extensive protocol here, Constantine. Do you think in a couple minutes you can just take us fly through this real quick and tell us some of your thoughts about deformity correction?
Sure, Mark. So let's we can go ahead and skip to the next slide, and we'll just show a couple cases. So here's a case of a Varus ankle deformity, previous surgery. And if you go to the next slide, I think a deltoid release is really important. Our knee colleagues release the MCL all the time, and we shouldn't be afraid to release the deltoid. And I start with the superficial, and I also do the deep. If you go to the next slide, I want to make sure I can get my ankle corrected before I do any part of the ankle replacement. Sometimes you have to make a separate lateral incision to remove osteophytes or bone fragments from that lateral gutter. So if you go to the next one, I can make my cuts, and I can try to minimize my bone cuts. And if you go to the next one, I still sometimes have to do the ligament. So what I tell patients is I'm going to put the ankle in straight. I'm going to balance the ligaments, maybe release the tight side or tighten the loose side. I'm going to check your flexibility. And I think ankle equinus contracture is separate from coronal plane stability. So patients can be unstable in the coronal plane, but still have a tight Achilles. And you want to balance the ankle. So here you can see the ankle replacement's in. And if you go to the next slide, here's the patient, and just give it a couple clicks, and you see I can still keep motion despite, and you can see here I've also done a first metatarsal dorsiflexion osteotomy. I think the first ray is very important both for flat foot and high arch foot. Now here's a bigger deformity, and you go to the next slide, and a big varus deformity. So go to the next slide there, Mark. And so you can't just use one replacement for all patients. This was a bigger patient with a bigger deformity, so I'm going to use a stemmed implant. I'm going to still do my lateral repair, but now I'm going to add a lateralizing calcaneal osteotomy, and I did a dorsiflexion osteotomy in the first metatarsal. So here you can see the replacement looks nice and stable, and give it another click, Mark. And here's the hindfoot before and another one, and here's the hindfoot after, so you can get much better alignment not only of the ankle but of the hindfoot. Go to the next one, Mark. Yep, there you go. So for valgus, it's almost the opposite. You have to think about all the procedures for valgus ankles. So if you go to the next one, Mark. Now, sometimes we get lucky, and valgus is just an ankle instability problem with uneven wear of the plafond. And this is a pretty straightforward ankle and a good one to start with. So if you go to the next one, but give it another click, Mark. All right, so now here's a valgus ankle, but there's more to it. There's widening of the syndesmosis. There's a flat foot. So we have to address all those components. So if you go to the next one, I'm going to put my ankle nice and straight, but I'm going to stabilize the syndesmosis, medialize the heel, and I need to stabilize that first ray. And when I really need to stabilize the first ray, I'm going to do a first tarsal metatarsal arthrodesis. I think that's more powerful than a cotton osteotomy. So if you go to the next one, Mark. Now this is a staged valgus. This is kind of a mess. You can see here the hindfoot's way in valgus, previous triple, bad ankle arthritis. So if you go to the next one, and a very flat foot. So I'm going to do it staged, and I'm going to use Dr. Haddad's trick. I don't know if it's his, but I know that he talks about it a lot, so I'm going to call it that. And I'm going to put cement in the tibio-talar joint space. I'm going to correct the talar tilt. I'm going to revise the triple. So I'm going to do a osteotomy through the TN and CC joint through my anterior ankle incision. I'm going to slide the heel over, and I'm going to wait for that to heal, leaving the cement in place. And then I'm going to do the ankle replacement above and give it another click. And there's the final AP and the before lateral, and then the final post-up lateral, and thankfully he's doing all right. Now, if you give it another click mark, yeah, so sometimes it's combined and I can't tell if it's varus or valgus or what am I going to call this. Go to the next one, Mark. So here you can see someone with a varus ankle. You can see the talar head's uncovered there medially. But if you give it another click, the foot's flat. So I have a varus ankle, but I have a flat foot and the talus is really plantar flex. So I can't put my implant on that talus when it's so plantar flex. And if you look at the hindfoot's pretty reasonably aligned. So we have compensatory deformity, a varus ankle and a valgus hindfoot. So I'm going to do it all at once. I'm going to realign the hindfoot. I'm going to pin it. I'm going to go ahead and do my ankle replacement. And I'm going to get it all set up. And once I get my ankle in, now I'm going to, and of course I had to do a brostrum because it wasn't enough to do the hindfoot and the ankle. But once I get it all lined up, I'm going to put in my fixation for the TN and subtalar joint. And if you give it another click, and here it is post-op. So I've corrected the ankle and I've corrected the hindfoot and gotten the foot plantigrade underneath the ankle replacement.
That's extraordinary. Great work. So let me ask you too, just is it important to preserve the dome? We got all these great implants that do this resurfacing. And here I am spending all this time with the ankle that I use to try to get this dome prepared so I can preserve all that bone. And, what if you have like crummy bone, really poor bone quality? I can't do that. And so in these cases, they're great implants. Either I can do the fusion, the arthrodesis like we showed, or there are now these flat top, or there have been these flat top options as well, just cutting all that bone away. And then here's a case I did where I just went ahead and cut it away. And so I'm wondering, is it really that important for us to work so hard and machine all this and engineer to try to save the dome? So why not just go to a flat top in every case? Just some thoughts. Does everybody use a dome component, or do you go to a flat top, and when do you use which one? Who hasn't said anything in a bit? How about if we have Tom mention? Do you have a thought on this?
Yeah, I think I'm probably more of a chamfer for the probably 80% and 20% for flat. And my determination is like what some of the things you showed, like if there's erosive changes, cystic changes, where I think that if I tried to do a chamfer, it would be difficult to get that contour. Vascularity too. If it seems like there's partial AVN or the bone doesn't look good at the very superior portion of the talar dome, then I might be more inclined to do a flat cut. I think chamfer does give you a little bit more rotational control, but I think either one I think would be fine. Flat cut is certainly faster, I'll tell you that much. And you just need to get down to good bone, bleeding bone.
What about you, Tim? You showed us some beautiful cases with big alignment, big deformity. Talus seemed to be, but it seems like you're doing a lot of resurfacing. Do you use a flat top talus too sometimes?
Yep, I do, Mark. And I think bone preservation is important. You have to think about your next operation. And fortunately, talar preparation and most of the new systems coming out is pretty slick. It's not near as complicated as it used to be. So you can prepare that talus once you get used to the system you're using in a fairly quick order. You don't necessarily have to go for a flat cut on your first option.
Hey, so I'm going to piggyback on that. So Tim, there's a question that came out. How long are you counseling patients that the implants will survive with their first total ankle? And secondly, what do you guys say to patients who come in and they've seen other people who said, ankle pain after ankle replacement is not pain-free, or it's not a great surgery? So both those questions, survivorship and the continued belief that ankle replacement is not a good surgery, doesn't provide pain relief.
Well, I tell most of my patients that we've got a good solution for 10 to 20 years, be it a fusion or a replacement. Eventually, you're going to run into trouble with both if you live long enough. I've got star ankles out there that are 20 years out. I just saw one a week ago. As far as I've devoted the last 10 years, Selene, on getting the pain-free ankle replacement. And I am a firm believer that we can achieve that as long as we pay attention to all the things we've talked about today. And the big one is alignment. Constantine showed some great cases where it's all about alignment. There's a few things that each of us, we've got our tricks, but I can assure you that a pain-free total ankle replacement is doable in 65 to 80% of patients if they have the right combination of surgeries done with their replacement. It really, my pet peeve is people will throw in an ankle joint replacement and ignore everything else. The patient doesn't do well, and then they say ankle replacements don't work. Well, if you don't do the right operation, no, nothing's going to work.
Hey, Hodges, let me ask you, I love that question too, but a lot of these, like this component, I've had some trouble, and I think you probably have too, and I'm sure Tim and Selene for that matter too, and even Tom, with the tibial component stability. So, if I have any question, I'm going to put in a stem component, and Constantine made that point before. So can you just run us through your indications of when you use a stem tibial component?
Yeah, I think the stem tibial component, I mean, let's go next slide. Is really the main stem component that's out there, surrounded by a lot of IP, is the end bone, and it's a segmental tibia, and the end bone has been shown to be the best tibial component that has been ever studied. This is out of your group, Mark, 98.8% survival rate with the stem component. This is out of Steve Haddad's group, 100% survival, and this is in the next. And this is out of our group at minimum 5 years, at 7.5 years average, 126 patients, 126 primaries with 100% tibial survival rate. So we know that the stem tibial component is a great tibia. And I believe it's a great tibia because first, initial intraoperative stability is bar none the best. Second, you get side press fit, which is a secondary benefit for rotational control. You get modularity with coverage, so you have sagittal coverage, which I think is super important. And then next, and then the stem, for whatever reason, does not give you stress shielding, which is kind of interesting, and it's a bit of a head scratcher. But I think you don't want it too tall to get into the varus part of the isthmus. I think it's better off and more stable in the other. And then finally, for anything that's got deformity, in my hands, gets a stemmed implant. So you can see this very similar. And I would echo what Tim said and what Constantine showed, is that if the foot is not aligned, which means all those other operations, the ankle, it doesn't matter which ankle you put in, is going to fail. And that's the reason why I strongly believe that ankle-trained surgeons should be doing this operation, not trauma surgeons, and not ankle replacement. Total joint surgeons for knee and hip. Thanks.
All right, we got 2 minutes left. We have some surgeons here with experience. This is one of my cases. I think this is fascinating, and I just, I'm such a doubting Thomas. I don't want to trust it, but I need to trust it because it works. And Hodges, you have lots of experience with this. Constantine has good experience. So Constantine, just in the last 2 minutes that we have, just run us through here your slides on patient-specific instrumentation.
Yeah, so I think patient-specific instruments are great because you're planning the surgery ahead of time. You're using a CT scan with great bony detail to align your cuts. And now we're able to use weight-bearing CTs, and we're able to get CTs that go all the way up to the knee. So we can get the true anatomic axis of the tibia. And so I've really enjoyed using patient-specific instruments, but are they really better? Well, we showed in our study in 2019 that give it one more click, Mark, it's equivalent. It's just as good as standard instruments, but it's certainly faster, less operative time and less fluoroscopy time, and that's a good thing. We want to be more efficient. And what's the future? Well, we have alignment guides that are patient-specific. Well, what about patient-specific cutting guides? And so if you give it another click, Mark, so now we can also do patient-specific cutting guides. So you get it right on the tibia, you pin it, and off you go. You can make your cuts. And with some of these now, you can also align the implants. You can align the talus with rotation, A to P positioning, medial lateral positioning. So, this is going to be something for the future, certainly.
Mark,
Yeah,
that's
all right.
that we can end.
We will end. Hodges, just 10 seconds. tell us, you have great stuff here. You have lots of experience with this. Is it? If
The
you have
bottom
the
line
choice,
is this
yeah.
with PSI. The bottom with PSI is it takes this technology and it makes it available to more docs, because the average surgeon for toe ankles does 5 to 8 a year. This puts that in those docs' those hands with a zero learning curve. This gives more patients more options for ankle arthritis. End of story. End of discussion.
End of session.
There you go.
Guys,
Perfect.
thank you so much. Like Mark said, we could have spent an entire few hours or an evening doing this. So thanks for kicking us off with a really stimulating session. For everybody watching, we're going to come back in a few moments. And thanks again for the panelists on this first session. And thanks to Smith and Nephew.
Thanks for including us.
Thanks,
and
Mark.
Great job,
Awesome.
everybody. Great work.
Good
on
job, everybody.
Good work. All right. Have a good night and good weekend. Good luck, Selene.
Ciao.
Thank you, Selene. Thanks, Mark.
Great work.